Hi, my name is Mike Hayden. I'm an orthopaedic hand and wrist surgeon. I'd like to talk to you today about a common condition known as trigger finger. Well, trigger finger is really common and cause a painful snapping of the finger. And here's a video clip of a classic patient that I recorded in the clinic recently showing classic trigger finger. Occasionally the trigger can lock the finger, and in this case the patient is very painful, and forcible reduction of the snapping can cause extreme pain. Usually we get patients before the finger has become permanently locked. Trigger finger occurs in two age groups. Often before the age of 3, patients may have a thumb that's slightly bent over, and this is often called trigger thumb. 2 of my 3 children have had trigger thumb, and I'm pleased to report that in over 90 to 95% of patients and children, this naturally resolves without any intervention whatsoever. And indeed, that was the case with my 2 children. However, in the adult population, that's slightly different, and the vast majority of these don't settle on their own, and the painful triggering persists. The first line of treatment is often a steroid injection. A low-dose corticosteroid injection is placed alongside the tendon in the fibrous sheath that goes along the digit. We're not entirely sure how this works, but we think it probably lubricates and reduces the inflammation. Trigger finger is caused by friction between the tendon and the overlying sheath as it goes in and out of the finger. And we often say there's a nodule on the tendon. When we explore these surgically, we often don't find a nodule, but we find some lamination or some irregularity on the tendon, and this causes friction as the tendon goes in and out of the finger. As the finger flexes, the nodule comes down, and as it straightens, it goes up. And if there's a nodule on the tendon, it catches as it goes in and out of the sheath. And we think that the steroid injection somehow reduces this friction. Trigger injection is probably about 70% successful. It can be performed in the outpatient procedure as a relatively painless procedure. So in that 30% of patients where they only get transient benefit and the triggering comes back, we often perform surgery. Under local anaesthetic as a day case, a small incision is made at the base of the finger. The nerves and the blood vessels are moved out of the way, and the sheath is identified. And a small 1 centimetre incision is made through this sheath. And this is a pulley system, and in particular it's the A1 pulley. The beauty of doing this with the patient awake is the patient is triggering before the surgery, and then once this A1 pulley has been released, we can ask the patient to make a fist and release their finger, and we can show the patient it's been adequately released. Likewise, the surgeon can know that the surgery has been initially successful if the patient is unable to trigger. Small stitches are put into the skin and a bulky dressing is applied. The bulky dressing is removed after 2 days. The wounds are kept clean and dry and covered for a period of 10 days, but we often ask patients to return back to pretty normal activities within 3 or 4 days. There are risks associated with any surgery, and in particular in this case, the blood vessels and the nerves are on either side, and it's important that the surgeon protects these and moves them to the side and incises and cuts the A1 pulley under direct vision. We often quote 90 to 95% success rate with trigger finger release.